Our topic today is spasticity. My name is Jody Gutkin. I am a physical therapist from the baccalaureate degree days. I have been practicing for over 25 years. Crazy to say that, but I have enjoyed, relative to this topic, teaching in many different settings and practicing, I should say, in many different settings that will lend itself to my teaching of this topic. I have worked in the pediatric setting for the neonatal intensive care, home care, school setting, as well as outpatient individuals who have experienced neurologic insult, head injury, spinal cord injury, stroke. I've worked in the acute care setting. I was a therapy supervisor of an inpatient rehabilitation unit, and I've also worked in outpatient and moving to Florida, the skilled and home care settings. In my second life, I am a physical therapy educator, so I hold my master's in education, which lends itself to this teaching format. It specializes in online teaching. And I look forward to imparting my experiences to you and also really delving into the research and kind of getting back to basics a little bit on physiology. I feel that gives us a good basis to make our clinical decisions moving forward. Our topic today is on spasticity. This seems like something that everyone learns in school and we know the technique. What happens over time? What is the research telling us are the new methods to utilize? And for the most part, we're finding that the traditional techniques we've been using are still the successful ones. So we will take a look at this. We'll analyze the current literature looking at the pathophysiology of how spasticity develops. How do we evaluate and assess it? And then how do we treat it with our rehab techniques and other types of interventions? The reason that I developed this course is, as I mentioned, that over time we're busy in the clinic, we're practicing, we're utilizing techniques, and it's always good to take a check back and look to see if the techniques that we are utilizing are still the most appropriate ones. So what I've done is I've read all the research. I read well over 100 studies for every course that I present, because you're all very busy in the clinic with your hands-on practice, right? That stack piles up with things you want to look at and may not get to. So any research study that I mention in the course is provided at the end of the PowerPoint presentation. And then I also provide a sheet with links to any of the assessment tools that I mentioned, so you can go back and take a look at those for during your clinical practice. I'd also like you to consider, as we're discussing spasticity, we have the benefit of our audience today being a nice mix of physical therapists, occupational therapists, and assistants for both those disciplines, as well as athletic trainers. So we're all seeing patients potentially who have neurologic insults where spasticity is one of their primary symptoms, but we also are seeing individuals who are at different phases of their life that present with spasticity, and now maybe they have an orthopedic injury. Or it's that child who had cerebral palsy who is now an adult that's participating in recreational sport and activity or fitness. So we really see patients across the continuum of care, both orthopedic and neurologic diagnoses that present with spasticity. So be mindful of that as we go through our presentation. Think about the different populations that you work with. We're also going to consider, as we go through our discussion today, some of the surgical techniques as well as the pharmacological management advances that we are seeing to treat spasticity. As with any topic, when you attend a presentation, when you go back into the clinic to utilize what we discussed today, you're going to perform that in accordance with any federal, state, and professional regulations for the location that you are practicing in. And that brings us to our topic for today. We can't talk about abnormal muscle tone without first revisiting what normal muscle tone is. And when we look at our muscles when they're relaxed, we have a natural tension in them. And this is typically high enough to support our activities, but it's low enough to allow us to have movement. It's kind of that continuous state of preparedness of our muscles to allow movement. It occurs as a combination of our neurological impulses as well as the viscoelastic components in our particular muscles. What we want to make sure we distinguish is muscle spasm from muscle spasticity. Both of those conditions are not volitional, so we don't voluntarily request our muscles to go into spasm or a state of spasticity. That's probably the only similarity between them. Muscle spasm is going to occur in an intact muscular system. We are going to see that as the result of maybe dehydration, muscle imbalance, where someone needs to stabilize themselves, or a protective reaction in terms of preventing further injury. If someone has, let's say, a whiplash injury, the cervical spine muscles will go into spasm to create stability. And that's a normal protective response that our body engages in. Over time, that healthy, intact muscle that's in spasm should release that spasm. Now, sometimes we need therapy in order to allow that healing to occur, but the muscle should relax and then it's back to its normal state. That's not the case with spasticity. Spasticity that we're talking about today is an actual neurologic condition where there is a change in the firing of the muscle, the neurologic region. The different tone alterations that can occur where we have high tone and increased firing of the muscle, not voluntarily, is spasticity, rigidity, and then if there's a lower firing of that muscle at its resting state, it's called hypotonia and flaccidity. Spasticity, by definition, it's a alteration in the muscle firing and a resistance to movement. And the key is that it is a velocity-dependent change in that resting state, in that resting tension of the muscle. And this is important to note because the more quickly you move a joint where a muscle is spastic around it, the greater resistance to that movement that you're going to feel. And that makes it more challenging for that individual to contract the antagonist or the opposite muscle to create movement. So spasticity is what we're focusing on today. And we need to understand how it develops so that as we're treating our patients, we have a good base for why our interventions may be working or may not be working. And we need to understand the difference, again, between our central and our peripheral nervous system. So we're going back in time a little bit to A&P from college, but I promise it will be painless. When we remember back to that healthy stretch reflex, if we look down at the muscle level, we have the muscle spindle that is located in our muscle. This is a sensory organ that senses the change in length of a muscle and the speed that that occurs at. If there is a quick stretch, this monosynaptic reflex from the sensory neuron is going to travel up to the dorsal root of our spinal cord. And I said it's a monosynaptic reflex. So that sensory signal of that stretch of the muscle goes up to the spinal cord. At that level, it goes over to an interneuron quickly, very fast, this Huffman reflex is, and that's going to send a signal down our efferent pathway to the muscle and tell it to contract. So there's a quick stretch sensed by the muscle spindle, and then a signal back to tell that muscle to contract. So what happens is when we're normally moving our joints, those muscle spindles are not sensing an overstretching or a quick stretch and giving that reflexive trigger telling them to contract. It's allowing us to have normal movement. So they've done EMG studies to try and figure out, well, at what rate can we stretch that muscle spindle and not trigger this kind of obligatory contraction of it, right? Because as we move, one muscle needs to lengthen so the other one can shorten with an active contraction. So they found that if a muscle moves through range of motion of about 60 to 180 degrees a second, it should not trigger this abnormal reflex response. And that's important for us to know later on when we talk about how we're assessing our muscle tone. So what happens when we have an injury to the nerve, to the pathway? If we have what's called a lower motor neuron lesion, that means the severing or the disruption of the signal is occurring out here somewhere in the periphery. So if we have a disruption of the lower motor neuron, that's out in the peripheral nervous system. That may be someone with, maybe they, put their hand through a window and they severed the nerve, or they have a nerve palsy distally after it comes out of the spinal cord. In that case, if we're severing the nerve at that point, there's no way for these signals to get up or down to trigger this monosynaptic reflex because the nerve is severed. It's like the bridge is out. So in these patients, we're going to see low tone. We're not going to see a stimulation of this reflex arc. Those aren't the patients we're talking about today. What we're looking at are the patients where the injury is somewhere here in the spinal cord and the brain, more centrally, that's not allowing proper functioning and balance of this reflex arc. And that's why we're going to see increased spasticity, that increased muscle contraction non-voluntarily. We're going to see increased reflexes in those patients also. The conditions that individuals present with where we will see a symptom of spasticity are going to be those neurologic conditions of upper motor neuron lesions. The American Association of Neurosurgeons estimates that there's about 12 million individuals worldwide who present with spasticity right now. When we look at the different diagnoses, individuals with cerebral palsy, about 80 to 90% of them are going to present with increased muscle tone. Individuals with multiple sclerosis, somewhere between 40 to 80% of them develop spasticity. And individuals with traumatic brain injury, spinal cord injury, and stroke also have a high incidence of the development of spasticity, as well as our individuals with Parkinson's disease. So some of these conditions are lifelong, where the spasticity may remain. Others, there may be some recovery that happens. In order to have a good sense of this, what we need to consider is the pathophysiology of spasticity. Well, why does it happen? And the research has looked at this, and they've come up with several different theories that they have been able to validate in the research. So they're finding that initially it is related to a neuronal response, that there's a disruption in the descending regulation of this reflex arc. So we have this reflex arc happening and nothing from the higher cortical centers are telling it to stop. And then we also have what's called denervation supersensitivity related to the nerve firing. Over time, secondarily, what they found developed is that there's a hyperexcitable stretch reflex that contributes. So the development of spasticity and why it continues in individuals is multifaceted. So Looking more closely at the disrupted descending regulation, normally we have a balance. So we have the individual who's moving. They have a overstimulation of that reflex arc down here at the spinal cord level with movement. And what should be happening is, what's happening in all of us right now is as we move, if we move too quickly and that muscle spindle is stimulated, our higher cortical centers are sending a signal down saying, you know what? You don't need to be firing right now. I'm just shifting my position here. I don't need to trigger spasticity of my hamstrings and an overfiring of them. So we have this dampening effect or inhibitory effect. What happens when someone has a neurological insult is that these pathways in the central nervous system are not giving that inhibitory feedback coming down. So this stretch reflex is kind of firing here unchecked, and that creates the spasticity. That makes sense. However, it doesn't really account for certain conditions where we don't see spasticity developing immediately. If that was the case, as soon as there is that disinhibition from the central nervous system, from the brain, everyone who has a stroke should immediately develop spasticity. Everyone who has a brain injury should immediately develop spasticity, but that's not what happens. So the research looked more closely at it, and this image I just thought was really neat. It's looking at the neural conduction and the synapses in an insect, and it's illuminating them with the microscope. And I just like it as a reminder that there's so much going on that we don't fully understand, but we need to be thinking as we're working with our patients and we're doing the exercises and activities that we talk about, that the nervous system needs time to respond. It's at this very smaller cellular level that we are trying to elicit an effect, and we need to be mindful of that. Denervation supersensitivity is something else that they've noticed is contributing to the development of spasticity. So what happens is our cortical spinal tract, that is what controls our voluntary movement and conduction of those neural impulses. So what happens when someone has a neurologic insult and they're not able to voluntarily contract their muscles is down at the neuromuscular junction, if I don't have voluntary signals coming down telling, these muscles to contract, those receptors are not receiving input. So what happens is those alpha motor neuron receptors, they kind of say, well, I'm missing something. Maybe I need to work harder to try and get the signal. So they actually start forming more postsynaptic receptors in these areas. They'll stimulate more postsynaptic receptors to try and grab the signal. Well, what happens is they actually found that they start to release kind of local growth factor. There's more neuronal sprouting that is occurring, and they actually have more pathways that develop. So now when that stretch reflex is stimulated, we have greater receptors here to grab that slight signal. Maybe I'm just shifting my position here, but now I have more receptors recognizing that input coming in, and they create a greater muscle response of contraction. So they've become more reactive to less of a stimuli, but unfortunately, it's not to generate power and strength. It's just to normal stretch and movement, that now the body is overreacting with a greater, more intense muscle contraction, not voluntarily, leading to more spasticity. And then combine that with the lack of the disinhibition from the higher centers, you can see why that reflex arc keeps firing even stronger. Over time in individuals, what happens is we have soft tissue adaptations. We know that muscle shortening occurs, that our sarcomere length changes if we're not moving through motion. So this patient has this spasticity of the biceps. Well, over time now, there's going to be shortening of that tissue. Those viscoelastic changes are going to occur from the lack of movement. And we end up in this cycle. So we have spasticity that's occurring. We have those viscoelastic changes, so a shortening down of the muscle, so that structural adaptation is occurring. Because of that decreased extensibility of the muscle tissue and that increased stiffness of it, it takes less of a movement to put tension on that muscle spindle fiber to elicit that monosynaptic reflex. So they have like a lower threshold. So it stimulates that reflex arc. That reflex arc itself is heightened because of the denervation supersensitivity, and the individual is stuck in this vicious cycle. And that's how spasticity is occurring. So it's really a combination of the neurological as well as the viscoelastic changes. There are different classifications of spasticity. Someone could have general spasticity, that's 2 or more regions of their body. Maybe it's the trunk, head, neck, extremities. It can be more regional, upper or lower extremity, or it could just be focal in a particular muscle group, depending upon how their condition presents. They looked at some research studies to try and see what the most common patterns of spasticity are, and what was noted is that it's most common in the upper extremity to have finger, wrist, and elbow flexors, and then the lower extremity we tend to see the knee and the ankle more significantly involved. When the tone presents in the upper extremity, it tends to it can present as extensor tone, but more commonly it's going to be flexor tone of the upper extremity. So we're going to see the individual with the scapular retraction and depression, adduction, internal rotation, elbow flexion, and pronation in this type of posturing. And then in the lower extremity, more commonly we're seeing in individuals maybe with cerebral palsy or following stroke, the extensor pattern where they have the hip and knee extension and then the ankle plantar flexion. There's also a tone pattern that presents in the lower extremity for individuals possibly with multiple sclerosis, head injury, cerebral palsy, where they have this adductor tone and knee flexion tone kicking in. For all your patients, you're going to assess the tone pattern that they present with to determine what your intervention needs to be. A class knife type of spasticity, when you passively move that individual's leg, you're going to feel kind of like a catch and a let go, similar to opening a pocket knife. Clonus presenting in individuals. This is when someone, for example, someone who has a spinal cord injury and they get out of it and they put their feet on the floor and they get that bouncing into plantar flexion. What happens is in reaction to that sudden stretch of the muscle, we have that muscle spindle activation. As we have that contraction of the muscle spindle contracting that gastroc into the tone, the Golgi tendon organ in that muscle senses the intense contraction and it says, well, I want to prevent injury from overcontraction, so let me relax it. So it inhibits that gastroc. Well, the stretch persists because of the position change, so now the muscle spindle is firing again, saying no, contract, and we're in this cycle. So it appears like a beating. It's an alternating loading and unloading of that muscle spindle. It's graded kind of greater than 5 beats is going to be an unsustained, or less than 5 beats, I'm sorry, is going to be an unsustained clonus, and greater than 5 beats is going to be a sustained clonus. Rigidity is when we have a tightness of both the flexors and the extensors in a particular region of the body, often in the trunk, in someone who has Parkinson's disease. And then decorticate and decerebrate posturing is going to be indicative of someone when they're in a coma state. If they have decorticate where their upper extremities are flexed coming into the core and then the lower extremities are extended out, this is going to be indicative of more cortex involvement where higher functioning of thought is occurring, and decerebrate posturing where the upper extremities as well as the lower extremities are out in extension is not attached to as strong of a prognosis for the individual. This often indicates more of a brainstem involvement that is responsible for our basic life functionings, heart rate, blood pressure, things of that nature. When we look at assessing muscle tone for our patients, we need to get a baseline of where they are at. Recognize that this is an involuntary contraction because of that reflex arc. So it's important to note that you can't perform manual muscle testing on these individuals because manual muscle testing is voluntary contraction. So when spasticity is present, we are not manual muscle testing. The tools that we're going to utilize to assess tone, the most widely utilized tool is the modified Ashworth scale. This was developed back in the 1960s and modified through the 80s. And this is going to occur where the clinician is going to passively move the patient's limb through the range of motion, and they're going to assess how much tone or spasticity they're feeling. It's a 0 to 4 scale that you're grading the patient on. And if you think about how quickly should you move the extremity, the idea is that if we normally move the patient that 60 to 180 degrees of motion in a second, it should not trigger the muscle spindle. We want to use that same rate of movement to assess the abnormal firing. So essentially, you're going to count your 1/1000 and move the patient through their range of motion. So that's the scale that you're utilizing in order to grade. When we look at the validity and the reliability of this scale, there's some discussion that it's not the best scale to utilize because it doesn't account for those viscoelastic changes that occur, that it's looking more just at the velocity dependent piece. They have shown in the research that it has good to moderate intra-tester reliability, only moderate to poor inter-tester. So if you and I both test, we may not get the same exact reading. It still is the most widely utilized tool for individuals with CVA, spinal cord, and traumatic brain injury, but they're not recommending it for use for individuals with multiple sclerosis. Another tool that's out there that is a little more mindful of the difference between the velocity dependent piece and that viscoelastic piece where you have the muscle shortening. This has the modified Tardieu scale has been found to be more sensitive to that distinction. It's a little more time consuming. The way this is performed is for each joint, what you're going to do is actually goniometrically measure the range of motion at 2 different speeds. So you're going to take the extremity and you're going to move it through a slow speed to get to the end point and goniometrically measure. The idea being that you have not triggered the spasticity, so this is giving you an assessment of the viscoelastic state of the muscles. And then you're going to take it through as fast as possible and again measure. So now you probably triggered the spasticity to see the range of motion, and then you do a calculation looking at the degree of range of motion achieved, what do you feel in terms of resistance, and you can analyze a little bit better. What they say is that it may allow you to catch more distinctions in improvement as well as worsening of range of motion that may help better guide your intervention. In 2017, there was a study where they looked at, related to patients with traumatic brain injury and spinal cord injury, the reliability of this tool, and they actually found that the intertester reliability was very high for both those populations. With CVA, the results varied a little bit more, but this scale, though it's more time consuming, may give you more information to direct your interventions. The patient-reported impact of spasticity, the Prism measure, this tool can be utilized to get the patient feedback of how spasticity is impacting their lives. And we need to think of this. We need to look at our patients broadly, particularly because with these populations, sometimes they do plateau, but we still need to come up with goals, or they're coming back to therapy, or athletic trainers, you're seeing them in different settings for health and wellness. We want to understand how spasticity is impacting their lives. So the Prism tool, it's a questionnaire. Think of someone who has Parkinson's or multiple sclerosis where they also have a caregiver who's involved. They may want to help complete the survey. And it asks questions, things like, the spasticity interrupted my sleep, or it helped me with transfers. Some patients utilize their tone to make their mobility easier. It caused me to eat less. It made me feel hopeless. It made me feel anxious about going out in public. So they rate things on a never true for me versus very often true for me. And it gives you a broader perspective of how the spasticity is impacting the person's life in many different aspects beyond just the pure function we're thinking of. Think of diet, think of hygiene implications. The Penn spasm scale, frequency scale, is a very quick scale that you can utilize. It has excellent test, retest, and consistency ratings. The Spinal Cord Edge actually recommends this as a tool to utilize with that population because it has a high correlation to quality of life scores. And literally, the patient is just going to grade their spasticity on the level that it occurs, and then how severe it is, the frequency and the intensity of it, to give you some more impact on how it affects their lives the hours they're not with us in the clinic. And this is important to think about influential factors and timing as we consider our patients outside a therapy setting. That often as clinicians, we're thinking more specifically about range of motion and function. But there are a lot of things that influence tone for our patients. I'll give you an example of a patient that I worked with early in my career, who I followed him. He originally had a stroke. He had an AFO. He was non-compliant with his wearing schedule, also a smoker and diabetic. Um, and he developed skin breakdown, ended up with an amputation also on that same side. So as we're doing gait training with his prosthesis, as he would increase his effort and become more frustrated, his upper extremity tone would start to kick in that affected his trunk, that affected his lower extremity, that all connected. So emotions actually play a role for patients in their tonal changes. Different stimuli, if the pain centers are stimulated, this can increase tone for a patient. It's important to know that tone can be affected by these other factors other than just positioning, because these exacerbating factors can be utilized in two ways. Patients who do not have an intact sensory system, they may get a sense, if their tone is increasing, it may let them or their caregiver know to look elsewhere for another stimuli trigger because something is changing their tone. Maybe that patient with Parkinson's, the spouse knows to look because it's getting more difficult to put their pants on because their tone is increased. Well, maybe look down at their toes. Do they have an ingrown toenail? Or someone with a spinal cord injury, do they have pressure sores, or are they constipated? And that's what's increasing the tone for them. Maybe a urinary tract infection is developing. Think of parents with children, or even when the child becomes an adult with cerebral palsy and they can't communicate what they're feeling. And what's going on with their other body systems, changes in tone, maybe the red flag that other body systems are being compromised to investigate further. There are complications that can occur as a result of spasticity over the long term, and these are also opportunities for us to improve our patients' overall quality of life and look at our goal setting. Think of that patient who has upper extremity tone, whether it's unilateral or bilateral. Even if it's unilateral, if they have this increased upper extremity tone, over time, those pecs are going to tighten down. The shoulder becomes rounded. The thoracic cavity tightens down. So now that's decreasing their respiratory capacity. It decreases their chest expansion. So now maybe they're at a greater risk of atelectasis or pneumonia. Think of nerve compression in that same patient with upper extremity or even lower extremity if that's that hamstring contracture. That we can have nerve compression can lead to carpal tunnel pathology or compression of the popliteal area. That can lead to pain for an individual that they may not be able to communicate, that we should be mindful of. Hygiene is something to be very important to be aware of. When I worked in pediatric home care and I had the infants where they would have diaper rash and they would cry and that would increase their tone, or just the rash would increase their tone. Mom has their child who is in pain and uncomfortable. They're struggling to change the diaper and the baby has adductor tone and they're in there trying to pull those legs apart. We'll learn our manual contacts that we use change tone. The parent's actually increasing the tone as they're trying to pull the baby's legs apart, and they're in this vicious cycle for everyone. Whereas if I just taught them to use neutral technique, flex the baby's hips, weight bear in, slowly move them out, use a quiet voice, it can be a better experience to change that diaper for everyone, and it improves hygiene, decreases risk of reoccurrence. So there's many ways that we can be aware of the global impacts on health and wellness for our patients from their spasticity. So keep this in mind also in your goal setting. Joint subluxation occurs in some individuals who have spasticity. They have looked at several studies of children with cerebral palsy who move into adulthood, and what they find is that the significant hip flexor adductor tone and this positioning of the lower extremity, when we look at an x-ray on the left-hand portion here, you can see that the femoral head here, in comparison to the acetabulum, that's down here more now, is subluxing from that tone. For some individuals, this may be painful. They may not be able to communicate, or it may be silent. What you tend to see if you do have the opportunity to look at the x-ray is more of a teardrop shape occurring here of the acetabulum from that shift and that rubbing. Over time, what they've looked at is that if these individuals go on to have a total hip replacement, the research is actually showing that they do not have a greater increase in dislocation rates, that they're actually finding, because the pain is decreased, which is a trigger for spasticity also, that some of the individuals actually have greater mobility and it improves their overall functioning. So when we look at our considerations for treating an individual who has spasticity, we're looking twofold. We need to manage the neurologic component, that hyperactive muscle contraction, and then we also biomechanically need to look at that soft tissue shortening. So as we develop our rehabilitation goals, we're going to prevent complications for the individual. We're going to consider their functional mobility, which is often the first area that we consider, as well as their independence with activities of daily living, their fall risk. We also want to be mindful of the psychosocial piece, that many of these aspects can leave someone feeling dependent, that it may limit their social interactions, which again impacts their overall quality of life. So we want to be aware of that. Also consider the impact if someone has decreased mobility and they're unable to feed themselves or they're unable to eat appropriately, or a caregiver is unable to perform the hygiene that's needed, that this can lead to compromise of other body systems. That patient who is diabetic post CVA, now they are unable to feed themselves and maybe not as effectively, so they're eating less. That may change their management of their diabetes. Now that may lead to greater complications from that condition also. So look at your patient holistically in your goal setting, and know that when we pick our interventions, we are going to balance our interventions. We're going to look at contracture management and trying to control those viscoelastic components. But we're also going to inhibit the spastic muscle. I'm just going to use my biceps a lot because I could get them on camera. We're going to inhibit the spastic muscle so it relaxes and we can get range. And then we're going to facilitate contraction of the antagonist to now utilize that range of motion. And then we're going to put all that together so the individual can get back their movement. As we accomplish this, we're not going to forget our basics. We're going to remember our positioning for patients. When we look at individuals who have high tone, consider the hours that they're not with us, whether they're in a chair or they're acute in the hospital in bed. We want to look at positioning individuals with different support devices so that they do not have to utilize muscle contractions to hold the different positions, because this can increase their tone. So we have a pillow here giving good support to that head and neck for alignment so the individual can engage with their environment without increasing their effort. We'll have support of that scapula. If the individual's side lying, we can put towel rolls here in order to support those hips. We're going to be mindful that we need to have position changes, not only to decrease the development of pressure sores, but also so that we can change positions to help alleviate the tone. Side lying is actually a good position for patients who have a reflex called the tonic labyrinthine, where when you're supine, it facilitates extension, and prone facilitates flexion. So when you put them side lying, it kind of negates that reflex, and you can support them with other devices so that they can engage more with their environment. We consider positioning of this individual that we looked at previously with the hip subluxation, just getting the individual in a new chair where there is a head support, then trunk support. Give upper extremity support and some weight bearing so you can get thoracic alignment that shifts the hips, shifts the lower extremity, and by taking the stress off the different systems, not in muscle components, not trying to balance against gravity, hopefully that can help contribute to relaxing that individual's tone also. And what we're picking up at this point in time are our intervention selections. What treatments should we be utilizing for our patients who present with spasticity? And this is kind of the great debate across the disciplines and even within the disciplines. There was a 2014 Cochrane review, because I'm a let's go to the research person and see what it says today. And in 2014, they did a Cochrane review. That's where they go out and they kind of pull all the studies on every topic. And they pulled 31 different studies, and some of those were systematic reviews themselves, so they pulled from other studies. So essentially, they looked at about 500 different analyses and multiple different rehab techniques, and pretty much what they can conclude is that there's a lack of consensus as to the best way to manage spasticity, that it really is multifaceted, that different things are going to work for different patients. So we need to just look at each patient individually and see which techniques work. So the good thing for us is that the techniques that all of us learned back in school many moons ago, or whether it was recently, are still supported in the research. And then there are some newer techniques that are emphasized also. So I am not claiming to be an expert on all of these. I am not specifically trained in NDT or any one technique. I like to say I'm a mixed bag. I analyze my patients, I see what works, and then I adapt based on it. So I'm going to give you little bits of all the different types of techniques that are out there to manage spasticity as a kind of a springboard and jumping point for your clinical practice and then other deeper research you want to do. First off, we have to look at the basics, the developmental sequence. And following this sequence is really helpful, and it will make it more likely for the patient to recover control, similar to a manner that volitional control initially develops for us. As we look at that infant who's developing, they're going to get that proximal control before they achieve their distal mobility of the extremities or even head and neck on the shoulder girdle. So it's important that we remember this when you're working with your patients, that we need to break things down into something achievable, especially when we have high tone. We need to decrease the tone, teach the patient now how to move and control in small ranges, greater ranges, and then put it back together in our functional tasks. I correlate it to this. If you have an orthopedic patient who's having difficulty with swing through and gait, that they're unable to get a good swing through, you're going to look at that patient, you're going to assess range of motion and strength, and maybe they have, a knee flexion contracture, they have hamstring tightness, maybe they have a weak VMO, weak anterior tib, a tight gastroc. You're going to work on those things individually, and then you're going to say, okay, now let's go put it together for gait. We need to do the same thing for our neurologic patients, where we take them through this developmental sequence. Let's achieve stability and mobility at each level, and then put it back together into the overall functional task. So for patients, we can work in prone on elbows. So for example, looking at that individual who has difficulty with head and neck control, maybe feeding is difficult, or paying attention in class, or just holding their head up to engage socially, we may put them down here in prone on elbows, work on getting that proximal stability of the trunk, inhibit the tone of the upper extremity, and work on that head and neck control. And then eventually gets into the point where they're able to sit with less support and actually feed and eat. It may not look the same as on the top. Our patient who is fully functional, we're going to need to give more cues and assistance in order to train the patient how to work with their spasticity and inhibit it for their movement. So the positions that you can work in, just to think about, we don't always need to be supine sitting, standing, prone on elbows, quadruped, kneeling, half kneeling. We're going to look at these different postures and consider that in all these different postures, we can use different techniques, weight bearing, approximation, and our hand holds to decrease their tone. Then we can facilitate the antagonist muscle, get some active motion out of that patient. So once the spasticity releases, we can go for range of motion and strength of the opposite muscle, and then we'll put it back together for functional use of the extremities. First thing we need to think about are how we're putting our hands on our patient. Our sensory receptors are very engaging and respond to stimuli easily. Think of that baby, that child. You put your finger in their hand, and what does everyone say? My baby's holding my hand. We know that's reflective. We're not like dream crushers when my family members tell us that. But we know that those sensory receptors are going to respond. So we need to keep in mind someone that already has a hyperactive stretch reflex, that if we stimulate it with our touch, it's going to increase their tone. So when you go to put your hands on a patient who has high tone and educate caregivers that they're more likely to be in neutral zones for the patient, that this patient down here who has high tone, if you're grabbing around their wrist here, you're stimulating those flexors. That may increase their tone. If that's that family member trying to help someone feed, if they're grabbing them here to see, here, let me help bring your hand to your mouth, you may actually be giving them too much tone that now they can't target appropriately, or leg with repositioning in bed. So what you want to think about when you put your hands on a patient who has high tone, you're going to go with neutral areas. You're going to come around the styloid process, not the flexors, holding the arm. You're going to come more around the femoral condyles to support that leg. And that patient who has high tone in the hand on the right-hand side here, if you come in and dig into the palm, or a caregiver does, because let's say the person's nails are digging in, you need to do, trim their nails and do hygiene of the hand. If you come and grab in here in the palm, just look at that in yourself. If you just scratch in here or grab tightly, it makes you want to close this hand down more. So the better way is you're going to get the thumb out into abduction. So you're going to use your thumb or fingers here, and you're going to pull that thumb out. And by pulling the thumb out into abduction, it's going to help inhibit the whole hand, where then you can come out and extend those fingers. So you might meet with better success. Weight bearing is beneficial in inhibiting tone for the individual. Weight bearing postures, that deep pressure over a tendon is going to be inhibitory. So this patient who may have extensor tone of the quads, as they're weight bearing here over these quad tendons, that prolonged pressure, and I'm applying some over downward pressure with my hand, is going to over time inhibit those quads. The pressure on the hand here on those finger flexors is going to help be inhibitory in that hand. So then maybe once we inhibit the tone in these extremities and quadruped, maybe now this patient can do a little weight shifting and engage their muscles. This child, if you're working with sitting activities, the clinician has their hand around the back of the child, giving some weight bearing down over here into the pelvis, into the lower extremities to work on sitting balance. What they could also be doing, if this child has upper extremity tone here, we see they're kind of in an extended and flexed down pronated position, why not get that hand open and weight bearing next to the child out to the side here? So as you're doing your weight shifting of the trunk and over the hips, you're getting more weight bearing through the arm and the tendons to be inhibitory around that joint. Because when we have a joint that has high tone around it, that compression of the proprioceptors around the joint will be inhibitory to that tone. And we know that everything's connected. And I'm from the day where the body wasn't split in half. One discipline didn't take the top and the other one took the bottom. Some of you may be laughing if you're in clinics like that. But that doesn't mean we still can't be mindful. If we're PTs working on the lower extremity or OTs on the upper, tone affects the whole body in many patients and can impact your routine and your outcomes in a different area. So be mindful that weight bearing anywhere can help inhibit that tone. They've actually done some research studies where they looked at patients who had a stroke and they participated in weight-bearing activities, prone on elbows, modified plantigrade, and quadruped before their therapy session compared to the population in the study that didn't have the weight bearing. They just went into their therapeutic activities. Those who participated in the weight bearing activities had improvement in their modified Ashworth scores, and they also saw that the patients were better able to achieve greater range of motion because there was more inhibition of their tone. So sometimes just weight bearing is helpful. Approximation is where you're applying an overpressure down through the long axis of the joint. So here we have a patient who may have difficulty with maybe bed mobility, getting out of bed from that side lying position because of that upper extremity tone. So I have her here. She's weight bearing down through that elbow and I'm applying approximation and weight bearing through that hand for the pressure on the tendons. So then once that tone inhibits a little, I can work in small range to see if she could start pushing up and then eventually get her into sitting. If we're working in the standing position here, we're having weight bearing down through that long axis of the hip and the lower extremity to help inhibit that lower extremity tone. We also have weight bearing and modified plantigrade here through the upper extremity. So that patient may be doing reaching activities with their uninvolved arm, the left, with the cones, weight bearing through that right upper extremity to inhibit tone in those biceps and that trunk. And actually my goal may be weight shifting so that I can get her to take a step for gait, but I'm looking at everything together for this patient. Consider that also in your patients where the positions you're doing activities in. If you are working on, let's say, slides to get hip flexion and knee flexion, whether you're an athletic trainer working with the individual for health and wellness, you're an OT who they need that for addressing the lower extremity, or a PT or an assistance for gait. Consider this patient that we looked at earlier. If you have her supine trying to do a heel slide and she has all this tone, you may not meet with much success. But if in supported sitting, like the top left image, imagine they're in supported sitting, we can get weight bearing down through the foot. We can give some overpressure with our hand down through the knee to inhibit the tone. And maybe now that patient could just slide that foot ever so slightly in a closed chain position to get some range of motion once the tone is inhibited. That might be much more successful and maybe even functional, because then the patient could learn how to reposition themselves than trying to do that heel slide. On the right-hand image here, when I work with patients, particularly in peds or individuals with MS, where I need to stretch the rotators and the adductors because of that viscoelastic component, I like to have them up in supine in this 90-degree hip and knee flexion. I'm supporting in neutral areas around the malleoli and then the femoral condyles. I can apply overpressure, tractioning down, approximating down into the hip to inhibit tone as I'm doing my range of motion. So I can approximate if the tone increases as I stretch, let it decrease a little bit, and then go back into my stretching. So lots of different ways you can apply these concepts of approximation to help inhibit tone to make your gains for active movement or stretching. Once we inhibit a muscle, we want to elicit voluntary contraction of the antagonist, the opposite muscle. So if we have that same patient here on the left where they had high tone in the biceps and the upper extremity, we're in that weight-bearing posture with the arm extended, and what I'm doing here is tapping over the triceps. Because as I tap over that tricep muscle, and it's a brisk, quick tap. So the muscle fibers, I'm going to use my wrist extensors here, but run this way. If I tap here, I'm kind of in between the muscle fibers. I'm not going to be giving a quick stretch to them to encourage contraction. So we want to be this way across the fibers. And if you do it in yourself, even if you brisk tap you can see that you almost start getting a little bit of a contraction. It gives a little micro quick stretch, and it's brisk and quick to that muscle spindle of the antagonist of the spastic muscle. So it's telling this muscle to contract, which further tells that spastic muscle to relax. So it has a twofold benefit, and then you're actively asking the patient to work with it. So here I'm doing it to the dorsiflexors to try and get dorsiflexion out of the patient, here to the triceps in that weight-bearing posture to encourage contraction. And with everything we do, we're mindful of that tone. So even here on the patient that has lower extremity extensor tone, I've done whatever technique I've chosen to inhibit that gastroc. See how I still have them flexed up over a bolster to break up that extensor tone pattern. By flexing that knee, I'm making it even more helpful to the patient, to their nervous system, to try and elicit this contraction of the anterior tib. So really, I love neuro rehab because it's like a puzzle, like you're building and you're layering and you're looking at the response and you're trying different things to see what works for the patient. When we look at skill progression for our patients, we're considering that when we work through the developmental sequence, we want our patient to be able to obtain the different posture in the developmental sequence. We're not going to want to pull and grab them because we could be facilitating the wrong muscles and increasing their tone. We want to encourage normal movement as much as possible. So we're going to use points of control. On the left-hand side here, this patient, if I put them prone on elbows and they're kind of like buckling down into cervical flexion and then protraction of the scapula and that rounding of the shoulders, instead of trying to kind of like, push and pull them up, what I might do is see if I could get the patient to actively contract into extension or actively contract here into my hands. Because if someone pushes against you, you're going to want to push back. So try to encourage that patient to push up into a posture. When they're trying to come up into prone on hands, I'm facilitating here. I'm showing them what the normal movement should be. And then from the hips to get them up into quadruped, giving them the cue for the weight shift to try and train their nervous system for the carryover of what normal movement should be. So you're going to first teach your patient how to, or help them get into the positions. And then once they're in the different developmental postures, you're picking one that's at a lower level than where they're currently functioning or having difficulty functioning. So that patient who has difficulty sitting and controlling their trunk at all, you might be down prone on elbows. This patient here in the tall kneeling on the left, maybe that patient is having difficulty with swing through and gait. And by putting them in tall kneeling, now they only have to control the trunk, the pelvis, and the knee. They don't have to control the distal leg and the ankle. So we can inhibit tone, encourage movement of those proximal segments, and then put it back together for gait. So with stability, you're going to give the patient some perturbations. You're going to try to see if they can hold there. You're going to resist them in different directions. You're not, right? Think about it. When you're strengthening a really weak muscle, what do you do first? Isometric contractions. Then you look for your concentric eccentric. So it's the same idea. Once we inhibit tone and we're in postures that do that for the approximation and the overpressure, now we're going to ask the patient just to resist isometrically. Can you pull in that muscle that is high tone voluntarily and not elicit that obligatory spastic response? If you can, great. You'll give them more challenges. If not, go back to the weight bearing. Take it back down so you can find what range they can successfully work in. And then you'll continue to progress them to controlled mobility, where now they can go through greater ranges of motion. Maybe they can free an extremity. So this patient here is weight bearing on that spastic extremity, where hopefully we've decreased the tone. And every time she reaches for a cone with the other hand, she's creating range of motion, co-contraction. She's having to use these muscles now. Or this child here, maybe I'm working on his pelvis. He may be in tall kneeling or standing. And as he's reaching for these bubbles, we're getting weight shifting at his hips and control at the pelvis to see, well, how much range can he move in before that extensor tone kicks back in the lower. Okay, reaching this far out was too far. I'm blowing those bubbles a little closer this time. Or I'm approximating, I'm giving them a rest, I'm approximating down to the pelvis to let them rest a little more, inhibit the tone, then go back into the reaching. So with neuro rehab, this really is a balance, and it's often a slow progression. The hope is to get to the patient where we can get skill and locomotion. Depending on the level the patient's at, we may be working with them as commando crawling as their locomotion, crawling on all fours and quadruped. For our patients who are ambulatory and they do have upper extremity tone, we might want to use a device that allows weight bearing through the upper extremity to inhibit that tone, as we're working on gait training for the lower extremity because the trunk is all connected. Modified plantigrade is a great position because it can work on lower extremity and pelvic control while still giving some support to the upper extremity. And this can be utilized for our pediatric or our adult population. And it gives the patient a much wider base of support because you have the upper extremity. So I could be down here working with this patient. Maybe she's even doing sidestepping, but we still have a nice wide base of support from the upper extremity. And we're inhibiting that tone of the upper extremity because sometimes we do see in populations that they can be ambulatory, but they still have that upper extremity involvement. So we're being mindful of those connections. Pressure splints have been utilized to help provide support. Sometimes you just don't have enough hands to control all the different areas and give input to the patient. So here's a patient on the bottom left here where we were working on swing through for gait. So she had a spasticity of her quadriceps. So we had previously done techniques to inhibit the quads. And now what I'm doing here is tapping on her hamstrings to work on that knee flexion in standing. But I have her in modified plantigrade because it gives her a big base of support, so it helps with the pelvis control. And I have the air splint on her upper extremity to inhibit the upper extremity tone. What these air splints do is they're meant to be inflated with a one-way valve with your breath, so it gives a little bit of warmth also. They were inflated to about 40 millimeters of mercury. And the idea is that they help to inhibit spasticity through the cutaneous receptors, the pressure of the air splint, as well as the proprioceptors, because now you can utilize weight bearing for the patient. And what they found in EMG studies is that patients who utilize this for 30 minutes, they actually had decreased spasticity firing on the EMG and a calming down of the Golgi tendon organ and the stretch reflex. How do you feel when you see this? You know, think about the visual stimulation here, right? For some of you, it may be a lot. Others of you may be comfortable with it. But generally speaking, we would all agree that this is a busy, bright pattern. We have many different types of input into our body. And in particular, this type of input from our visual system can impact our nervous system and our tone. So when you're working with patients, not only do you want to think what posture you're working with them in, but you also want to consider sensory stimuli that they're receiving. So we receive sensory stimuli through many different types of input. Visual is one of them. And think about, as you're bringing your patient down to therapy, or you're a trainer working with them in a busy gym, that's a lot of visual stimuli. Someone that already has high tone, that may increase their tone even more. Even the brightness of the lighting may impact the individual's tone. So you want to avoid busy environments. Auditory stimuli are something to be aware of. That quiet music is going to inhibit tone. your voice. I'm a New Yorker, so I tend to get loud and busy and crazy, and I get excited when my patients are doing well. But when it's that patient with high tone, I have to scale that back because that may increase their tone and kind of have the opposite effect of everything that we were going for. So keep in mind that quiet environments, think of this for caregivers at home. If there were, caregiver for an individual with Parkinson's disease, maybe don't have the TV blasting, turn on the lights first thing in the morning as you're trying to help that individual get dressed. Maybe see, does that increase their tone? They did a study where they looked at patients who had strokes, and they had them listen to easy listening music for about 30 minutes before therapy. And they actually found that there was a decrease in their tone, that they had increased quality of life and functional score ratings, increased mood, so that there is something to be said for these different stimuli. Visual stimuli we mentioned. Vestibular stimuli is something I want you to think about. And this is something to consider using with your patients. I always joked that if I ever did open my own clinic and I was working with the neurologic population, half of my waiting room would have rocking chairs because my patients with high tone, I would put them in the nice smooth glider because that actually is found to be inhibitory stimuli to the vestibular system to help decrease the tone. And then I would have the rockers that go really fast for my patients with low tone to try and increase their tone before they came into therapy. But it's something to think about, and here's how. An individual who's coming in, maybe they're at a wheelchair level and someone is bringing them into outpatient therapy, if they are being kind of rushed through and moved quickly, that may be stimulating their vestibular system and increasing their tone. You might want to look at your scheduling of your time for therapy for them so that they're not rushed getting there, or so that there is time maybe for their tone to calm down a little bit before you work with them. And I've really found that looking at all these, what we call little pieces, they really have a big impact on your outcomes. When we look at the different camps, Bobath versus Brunstrom, for rehab of individuals who have high tone, we're going to first take a look at Brunstrom, whose theory of motor control is looking at individuals' recovery of active movement. And generally speaking, we're looking at the different stages where they move from a episode of flaccidity to spasticity to normalization of function. For the patients that we're talking about with high tone, generally they're presenting in stages 2 through 5 of the Brunstrom stages of recovery with some level of tone. And then the way that we look at tone is the spasticity is decreasing and they start to have a volitional movement that they can initiate as the tone is decreasing, the spasticity is decreasing. They say usually within 1 to 6 weeks post-injury, spasticity, if it's going to develop, it does. And Brunstrom developed this scale back in the 1960s to look at these phases of motor recovery. Generally speaking, Brunstrom's theory was that when an individual is recovering from a neurologic insult, that we want to encourage movement, that we need to find a way to tap in and reestablish a connection to the neuromuscular system. So however you can do that, do it. If it means increasing tone, well, you know what that means? There's a nerve to muscle connection that's working. If they're abnormal reflexes, okay, so it's not perfect normal movement as this individual is attempting to ambulate, but they're moving. We can try to normalize it after. That's going to be very different than the theory of Bobath, but stick with me with Brunstrom right now. So Brunstrom acknowledges that there's going to be that period of abnormal movement where that agonist-antagonist relationship is not balanced, but you're in. You have a way, a connection, so let's build on that. And associated reactions are something that Brunstrom uses in order to encourage movement. Associated reactions are this. Have you ever been carrying, heavy groceries in one hand? You have those, plastic grocery bags kind of strung across your arm, holding them there, and kind of your other arm starts to come up into flexion. Well, that's an associated reaction. What happens is that as, there's just certain connections, our nervous system is so phenomenal that as there is an overfiring of one muscle group, that somehow through the connections in our nervous system, another muscle group starts to kick in to help and make that easier. We kind of get what we call overflow or an associated reaction. Now, over time, as we integrate different reflexes, we really don't see this evidencing itself very much in typical activity. But when a person has a neurologic insult, they kind of unmask. So some of them have particularly been found to be helpful in rehabilitation. One example is Remistes. Remistes is looking at a patient, let's use the example of this patient here, who has spasticity of these left adductors. So they have high tone of the left adductors. I have the patient supine, so they have extensor tone in that left leg. I have them supine with the head a bit elevated because that tonic labyrinthine reflex, if someone's supine, it encourages extension. I want to give this patient the best opportunity to move. So by elevating the head of the bed, I'm kind of breaking up that reflex a little bit. I also am using a sliding board and a skate to remove friction. So I'm borrowing a little from Therex principles, right? Take away friction and it'll make movement easier for the patient. And what I'm doing here, so I have spasticity of the left adductors. On the right hand intact side, I'm resisting abduction. So the patient is pushing out here into right hip abduction, and I'm isometrically resisting them, so they have to work really hard. Remistes says that when we elicit abduction on one side, the abductors on the other side kick in to help us. So as this patient is resisting and abducting on one side, on this side where they have the spasticity, my abductors are going to kick in. So they're going to try and help the movement through that overflow. And this is great because what happens is as my abductors kick in over here on the spastic side, so they're kind of obligatory response here on this spastic side, these adductors that are spastic have to relax. Reflex inhibition says if the agonist is contracting, the antagonist has to relax. So we're forcing that spastic muscle to relax kind of through a back door. And hopefully then that patient will see their legs start to move out and you could say, look, feel that proprioceptive input. Let's make that connection. Now try to move with it. So it's great when we can use these reflexes kind of as another way in. It can also work on the upper extremity. Marie-Foi is another reflex that if we take the patient and we grab under their toes with our fingers, particularly the great toe and the other toes. So we're grabbing, we're kind of rolling them down and under. My other hand is here on the hamstrings, giving deep pressure to the hamstring tendon because we know that that's inhibitory to this patient who has extensor tone. And as we do this, what we're going to see is hip and knee flexion. So Marie-Foi can help break up that hip and knee flexion extensor tone. So what happens is I use this several different ways for patients. Sometimes you just use it to break up the tone to position that extremity. Once they can start getting some volitional movement, you can ask them to work with it, kind of like an active assisted heel slide almost, but we're using the reflex to help break up the tone. I get so excited when these techniques work and my patients feel it for the first time. It's like you're in and they feel that little victory, and then you can use that to build upon. As we take our patients who have high tone and we move them through different positions of the developmental sequence, or maybe it's a caregiver doing bed mobility with someone, we're challenging them, right? So when our patient with therapeutic exercise, we give them that 5-pound weight and they're doing shoulder flexion and they start substituting, we say, oh, that was too much, we're backing you down to 4. Our patients with high tone, when we're saying, great, we can move in this range, and then their tone kicks back in, we need ways to calm it back down. So gentle rocking is a great technique. What you do with gentle rocking, I like side lying because it's a reflex inhibiting posture if they have that tonic labyrinthine that they're dominated by. You put them in side lying, and what you do is you just gently kind of rock at the pelvis, anterior and posterior, dissociating it from the trunk, or up here at the scapula, gentle rocking, and that's going to help inhibit tone down the entire extremity. So it's good during transitional movements or taking a patient down, maybe that patient with Parkinson's disease or a head injury where a caregiver is trying to help get them up out of bed in the morning and they're stiff from all night. Maybe a little gentle rocking might help to inhibit the tone, and then they can meet with better success with movements. Slow stroking is another technique that can be utilized to inhibit tone. What happens when someone's sad? What is our instinct? You kind of come in and you rub their back a little bit. It kind of works on that theory that with someone who has high tone, so maybe I'm working with my patient in quadruped for pelvic control, trunk control, upper extremity, maybe general health and wellness. It's a good position to strengthen the core in, but their tone kicks in. What you can do is lie them back down into prone, and then you do slow stroking. It's best skin to skin, but from the occiput down to the coccyx, and you're kind of just like gently overlapping, slow and steady. And what they find is this is generally inhibitory to tone, and it helps allow more voluntary effort. So maybe you do that, calm them down, relax them, and they can go back into that activity. Or that parent caring for the child, maybe they inhibit the tone, and then they can roll them back over and do their, hygiene activities. Lots of different ways you guys can apply these techniques, and what you need to do is try them, see how the patient responds, and then modify from there, because it's not always a predictable response. Look at your environment. Some of those other auditory visual stimuli may play a role also. So don't try something once and say, oh, that didn't work. With neuro rehab, you need to be looking at every different input and all the different variables to try and meet with success. I think that's what makes it so rewarding for yourself and your patient. Cryotherapy seems simple, right? Using cold, but it really does work well. I must caution you, you have to check that your patient sensation is intact because you don't want to cause tissue trauma. What happens with prolonged icing, so a long application of cold over that spastic muscle that's constantly firing that reflex arc, cold decreases nerve conduction velocity. So if we're decreasing nerve conduction velocity of this reflex arc of the muscle spindle firing, it's going to slow down the reflex. So a lot of times what I did was a patient with multiple sclerosis where I need to be stretching their lower extremities in that supine position, kind of, hook lying. I would have the cold packs on their arms and their biceps inhibiting that for prolonged cold application while I stretch their legs. So then we're ready to go back into our developmental sequence. What they found looking at individuals who had upper extremity tone, they took kids 4 to 6 years old who had cerebral palsy, and they applied cold packs to the upper extremity for 20 minutes. They found that those individuals had better Ashworth scores, and they actually had better Peabody scores. The Peabody is a test that looks at kind of mobility and different skills at different milestones, that their scores improved. They were better able to recruit their muscles after some training. We can also use cryotherapy in the opposite way. What happens when someone throws ice cubes down your back? Can you remember that as a kid, right? Oh, cold. It's facilitatory. So we can use it the other way, that if we just inhibited a muscle, let's say it is, pretend this is my anterior tibialis. So I just inhibited the gastrocs through weight bearing or whatever techniques I utilized. Now, instead of tapping that anterior tib for dorsiflexion, I can take an ice cube from insertion to origin. Ice, insertion to origin, and ask the patient to volitionally contract. It should help improve the contraction of that muscle. So it's going to facilitate. But again, the key has to be from insertion to origin, because you're kind of recruiting the fibers in that direction. Brunstrom, with all these different techniques, has said, and these are just a sampling of them, that you're going to try whatever you can to get into the neuromuscular system. Use different reflexes to encourage movement. Bobath is the other camp that says, no, only encourage normal movement. Because you want the nervous system to be retrained with normal patterns. It's a lot more difficult to unteach bad habits, so to speak. So only encourage normal movement is what Bobath says. So there was a study that looked at all the different techniques, and they really were trying to decide, what is better, NDT versus Bobath, and they really didn't find that the research could say one is better than the other. Again, you need to evaluate your patient, look at the techniques, and see what works best for them. Looking at Bobath theory, this is neurodevelopmental technique. The idea is that it is task specific, that you are minimizing compensatory unnecessary movements. You really want the patient to only feel normal movement and encourage that to promote efficiency, correct motor patterns with correct speed and balancing of muscle contractions. And the idea is that let them feel normal, let their proprioceptors and their sensory system recognize that to reinforce those pathways. So anytime a patient moves into an abnormal pattern or their spasticity increases, Bobath says then you're backing off at that point. The way that Bobath accomplishes this is through what's called key points of control. They're breaking tasks down into their smaller pieces so patients meet with success, and then putting it back together. So Bobath uses key points of control of the scapula and the pelvis to control postural alignment for the patient. And this is going to give normal input. When you put your hands on the patient, when you're using NDT technique, you're not grabbing, you're not pulling, you're not moving that way. What you're doing is, I have here, an open hand on the upper thoracic cavity, and then one is back here, you can see on the lower back. So you're like encouraging normal movement. You can imagine if I came in here, just here, even on yourself, if you were to try it now, just this, it makes you want to sit up. Versus telling the patient, come on, sit up straight, I'm going to pull you this way. Bobath uses these key points of control of the scapula and the pelvis to encourage movements. Another key piece is that everything is bilateral, it's symmetrical. When we move, we cross midline. Body-on-body contact are key concepts in the Bobath technique. Bobeth, as I said, wants to inhibit our abnormal reflexes. So it's going to look at reflex inhibiting postures to try and negate any of those reflexes that are increasing tone and shortening the muscles down. Bobeth doesn't want those compensatory movements, even temporarily. We want to give normal input to the body systems. So if Bobath was trying to flex up the lower extremity, Brunstrom would say, use that Marie Foix, bend that knee. Bobath would say, if you have this patient here that has this gastroc tone, see how they're down here in plantar flexion from the high level of spasticity in this diagram on the left. Erase that here. What you're going to do with that patient is when you come in and put your hand on, you're going to grab around that calcaneus. You are going to give pressure on the plantar surface of the foot. And then your upper hand is going to be rotating that leg out into a little external rotation. And that combination has been found to be inhibitory. So now you should be able to either range that leg and help diminish the tone to get some range, or if the patient can voluntarily then get some movement if you inhibit it enough, that you're using more your points of contact that way instead of using a reflex. Consider if you are working with patients, potentially they're orthopedic patients. Maybe you are seeing them for an ankle sprain or an, patellar tracking disorder, and they have a history of high tone from a neurological condition. Remember your positioning. If they have high extensor tone, just put them up on a wedge. So by breaking up that hip flexion a little bit, maybe it'll break up that extensor tone. If you're working with them prone on elbows to break up that extensor tone here in the lower extremity, see how I have a little roll under the ankle. So I'm just flexing that knee up a little bit to try and break that tone. Bobeth really looks at positioning and alignment. Humeral external rotation has been found to increase, to not only decrease the tone in the upper extremity, but also it's been found on EMG to increase the extensor activation. So what they did was they took patients who had upper extremity spasticity, and they did EMG readouts from C4 down to T10. And what they found is when they placed the arm here into some external rotation, if you look at the positioning of the patient's hand here, she's out in external rotation with the weight bearing, that actually increased the activation of the trunk extensors. This is important because it gives that proximal stability to try and get that distal mobility as we're inhibiting the tone. Also, remember, patients with upper extremity spasticity, we're decreasing that thoracic expansion. Those intercostals are shortening down. So again, if we get more extension, we can get better breathing also. So, and increase weight bearing on that upper extremity. So they found that getting that external rotation in positioning here is helpful to inhibit tone. Bobeth uses what's called the prayer position. In the prayer position, we're using body-on-body contact. We are stronger when we have body contact. It's also reintegrating the central nervous system to cross midline. Remember, a lot of these patients may have neglect if it's a head injury or a stroke, so you're reminding them neurologically of this extremity. And Bobeth specifically says that the thumb of the involved side is on top. So this patient here, this is her left arm, is going to have that left thumb out on top. And the idea, what Bobeth says, is when we abduct that thumb, we get inhibition of the abnormal tone that may be occurring in that extremity. So we get the body-on-body contact. And Bobeth will use this hand technique whether you're having the patient reach for cones, maybe they're grabbing things for dressing. If I'm in tall kneeling here, working on balance of the pelvis, I'm going to use that prayer position of the upper extremity to normalize tone in the upper extremity for that patient in order to look at giving normal input to the entire body. As I mentioned, key points of control are the focus that Bobath is utilizing. Imagine this patient, if you were going to help them sit up straight, where would you put your hands? A lot of you may say, I'm wrapping a gait belt around them first because I'm afraid they're going to fall when they go to get up. And I'm going to what? I'm going to maybe help push them up from this side. Maybe I'm grabbing around the thoracic cavity and weight shifting them. Bobath says all of that is abnormal input. That where you should be controlling the patient is think about how you would normally sit yourself up. You would push with your arms and you would recruit for your, weight shift onto your pelvis to weight shift your shoulder girdle. Well, why not put your hands on that pelvis to weight shift and then the scapula to weight shift, and through your manual contacts, give them input for normal movement and be telling their muscle system what to recruit so they're learning to move. You're not just getting them in the right position. So we're talking about the Bobath technique still. And I don't know if this technically counts as a Bobath technique, but it kind of fits here with key points of control. Trunk inclination is a technique that you can utilize to work on trunk control while helping to normalize the tone in the upper extremity. A lot of times when we're working on sitting balance with the patient, we're sitting behind them trying to control their balance, or we're in front trying to control from the shoulder girdle. The reality is if you and I were going to lean forward, we're using the stable base of our pelvis, and our scapula, right, is our kind of our control. Our shoulder girdle is where our control comes from. So what you do is you take the patient with their extremity that has the spasticity. You've done maybe some inhibitory techniques already. You're going to have them grab under that arm and be cradling the spastic arm. At this point now, you can see how that almost gives me a direct path to the scapula. And as the clinician, whether I have this patient sitting unsupported on a surface, or maybe they're in a wheelchair just scooted forward if I need that kind of safety and stability, and as I grasp around that neutral zone of their elbows, when I give force forward and back, I'm kind of tractioning through the shoulder and approximating through the shoulder to control that trunk for the patient. It's a great way, if I needed to, I could come further around with my arms and reach back here to control actually around the scapula and cradle the arms if the patient can't hold them. But I'm using that scapula to control the weight shifting. In this way, I can be encouraging, if they had high tone in the lower, weight bearing down through that lower extremity, kind of as a preparation for sit to stand. I can work in different ranges for that patient. You can do diagonal, you can do rotation, and it's just a nice way to work on trunk control using that scapula as a key point. For some patients, it might just be holding the posture. For others, it might be starting to shift within it. And the further you shift, the more weight bearing you can get on that lower extremity also. Again, encouraging normal movement. It's incorporating both sides of the body for that patient. The Bobath handhold, sometimes I utilize this also in sitting with patients. I'll be sitting next to them on the treatment table for sitting balance to control that trunk. When you have a patient, like in the diagram or picture here on the left, that has high tone in this upper extremity, you're going to get that thumb out of the palm as we showed, not grabbing, but trying to, just gently abduct that thumb. And then you're going to place your hand inside theirs, like in the diagram here, where my thumb is holding their thumb in abduction. My fingers are holding their fingers and wrist into extension. And then that almost creates a lever when I put it across my hip, where I can give feedback into the scapula, into the shoulder girdle, into the trunk. And you can envision here now Any way I move, I'm giving the same input from my movement directly to my patient, whether it's weight shifting, so I'm normalizing tone in the extremity that I'm holding, and now I'm giving input for normal movement, almost mirroring my body, and you can actually use this for gait, where you can weight shift the patient over, so now this leg can come and swing through, and I'm stepping at the same time to work on stepping, normalizing the tone in the upper extremity and giving them, again, a key point of control rather than trying to, with this patient, be in the parallel bars, one person at their leg, lifting their leg up and moving it. This may give some normal weight shift that may allow them to start initiating for that step. When we look at bed mobility for patients using our bow bath technique, bed mobility is going to be broken down into a segmental movement. We want the patient to meet with success and feel normal movement. So rather than having this patient on a draw sheet and just sliding them over, bow bath is going to say, use your bow bath handhold, have the patient reach up. So this patient is trying to reach up as far as they can. And again, it may not look pretty, they may not be able to go far, but you're coming around here on their scapula to weight shift them over. And again, you're not tugging and pulling. I have a good base of support. So my weight shift of my body to help is giving input to this patient of a normal weight shift. Because what, if I was lying in bed and I wanted to move, I'd kind of go up and over. So you're mirroring that, giving them normal input. And then on the lower extremity, what you're doing here is you're giving approximation and weight bearing down into the foot. So when you shift kind of down and in to the foot, and you can be helping lift up the pelvis for the patient so they can scoot it over. Now, it may take several scoots, but again, we're encouraging typical movement patterns. I love dynamic bridging. I think so much can be done in the bridging position, not only to help normalize tone, because when we flex the patient's knees and give weight bearing through the feet, we're getting all those benefits of inhibiting tone, but this is a precursor to sit to stand. It's bed mobility, it's sit to stand at a lower level, it's even right stair negotiation. Anything we do where we need hip extension, knee flexion kicking in. But you're at a low level where they don't have to control the trunk and you can manage their tone. So what you're doing is you're placing your hands on the patient, neutral areas of their femoral condyles, and you're cueing them for the weight shift. And I would encourage you after the course, take it, who's ever home, they're probably still in bed later, and flex them up and give a pressure down and into the feet. It cues that weight shift, it cues that motor response to make them want to lift that bottom up. So your pressure is kind of a combination of down and in to the feet. So it's almost like a traction this way or a distraction combined with a pressure down into the feet as one movement, and it can help the patient lift their bottom up. Now, again, our patients may not come up far, but because we're inhibiting that lower extremity tone, we're giving them some weight bearing, they may meet with better success with the movement. We could be under here tapping those glutes if we needed to give them some mini quick stretches to recruit them. You can resist the patient's pelvis. So in this image, I'm resisting the patient's pelvis. I'm having them push up against me. I'm trying to rotate them, see if they can stay stable. And I'm working on pelvic control for swing through and gait, but in a safe, stable position where if that lower extremity tone kicks in, I can back it off. I used to with the pediatrics, and even some of the older patients liked it. They get jealous. I put little blocks on their belly, and I would have them try to like flip it off. So it's almost like a mini, if you think about it, replication of the gait cycle, but just focusing on the pelvic control. So again, they can meet with success. I can go down into inhibitory techniques if the tone kicked in, and we're encouraging normal movement. I don't know that bow bath would like that, but like I said, I'm a mixed bag. The NDT transfer technique is a specific way of transferring patients that is used without a gait belt. The idea is that it encourages weight bearing on the involved side for reintegration. It crosses midline for the patient. When we look at the maximum assist transfer for the NDT technique, I always joke with my students, I'm an educator in a physical therapy curriculum. And you know, the first semester we teach, you always transfer to the strong side, it's more stable. And then in the last semester we say, okay, forget that. Now with your neurologic patients, you should always transfer to the weak side because it reintegrates that side for them. It has them crossing midline. If they do have a lot of extensor tone in the lower extremity in particular, so this patient, the left side is involved. So you can't see it behind my leg here, but that left side is going to have the knee flexed. I position the feet, so it's breaking that extensor tone. You're in a Bobeth handhold, and the patient is going to lean down and over their uninvolved side, so their intact side. What happens is, as they're leaning over, they're weight shifting, they're unweighting themselves. This side is going to work as a pivot point, a fulcrum for the transfer. Your hands are coming around their gluteal greater trochanter region. You weight shift them forward, over, and sit. So this is your max assist transfer. Keeps the patient as a nice tight bundle to inhibit that extensor tone. Again, it encourages normal movement because if I went to stand up, what would I do? I'd lean forward, I'd shift over, and I'd sit back down. So it encourages that typical movement pattern, and it's much easier for you as a clinician to handle the patient, particularly if they have tone. As the patient progresses and they only need moderate assistance to stand up, now you can use that scapula as a point of control. So you're going to have, again, they're transferring towards that involved side. So the left side is involved. The patient's in the prayer position to help normalize their tone. You're grasping here around their scapula to control the trunk. So your cue is the patient is weight shifting forward and up, and then down to sit. And again, your weight shift as a clinician, see I have a nice base of support here. I'm weight shifting back and over for them. I'm giving them normal input to help them sit down, letting them do as much as they can on their own. As the patient continues to progress and they only need minimum assistance for the transfer, as a clinician at this point, they're going to have positioned their feet. They're still in prayer hold. Now they just need the cue to get up to trigger the contraction of their neuromuscular system. So I'm here at their hands, and then I'm giving a pressure here down and in on the knee. So kind of down and in to get that extension at the knee. So you're telling the patient they're in a sitting position, come forward and stand, and then sit down. And I can tell you, if you try these techniques, you would be amazed at how it just triggers and primes the nervous system so the patient can better recruit what they have to encourage normal movement. Once the patient is able to perform these techniques on their own, what you're looking at in terms of the transfer for an independent sit to stand, if they still have some of that increased tone in their upper extremity, they can use a hand-over-hand contact on their own involved knee. So this patient is getting weight bearing. They're weight bearing through their own hand that has the high tone over the knee that may have the high tone or be weak on their involved side. And they are pushing themselves down and in, that cues that weight shift in order for them to stand up. And I'll tell you that these techniques really do work well, and if you try them on someone, often individuals are amazed at how it encourages the nervous system to recruit itself. And that is the whole concept of Bobeth, to give that normal input for movements. Looking at another technique, proprioceptive neuromuscular facilitation. This particular technique works under the concept that when we move, we don't move in straight planes. So if I'm going to pick up my water bottle, I don't say, it's here. I don't say I need shoulder flexion, elbow extension, shoulder adduction, internal rotation, Now bring it back in all these straight, plain, mechanical movements. We don't move that way. When we move in diagonals. If I'm going to get that seatbelt, I'm moving this way. I don't go get the seatbelt and pull it down. No, they're diagonal movement patterns. And PNF considers that we have that spiral component, that the sensory input we receive helps direct our different movement patterns. And when we look at utilizing PNF techniques, it doesn't only have to be for active movement. There are some techniques we're going to talk about specifically that you can utilize when your patient has high tone or when the tone is diminishing and you're getting active movement of that muscle that has been spastic. They have to learn how to contract it again, or the antagonist muscle. There are specific PNF techniques that work better than others. Here's an example. So let's say your patient has spasticity of their right upper extremity here. So we can see in this gentleman that he has some finger flexion here. The elbow is buckling a little bit because he has some spasticity. So we're trying to have him weight bear to inhibit the tone in the extremity. And what he's doing with the opposite arm is a PNF technique, a diagonal movement of his uninvolved arm to get that weight shifting on the extremity where we're trying to normalize tone and teach him how to move. So you might do movement patterns on the good side, quote unquote, to force the patient to stabilize, utilize, and move in different range of the involved side. Or you may utilize the techniques directly on that involved extremity. There are several different PNF patterns. I'm not going to go through all the details, but I did write them out on the slides so that you have the information. D1 pattern of the upper extremity. This is a pattern where D1 feed one, or some of you may know it as the shield. So it's where the arm is coming up across the body to get that hand towards the mouth. It's a combination of flexion, adduction, supination in the patient. This is a technique, if the patient actively contracts all those muscles, those are the muscles that are often spastic in the context that we're talking about. So you may not want your patient to actively do this technique if you utilized other interventions to inhibit their tone. So if you just inhibited the patient's tone, you might want to try having them actively do the D1 flexion pattern. But if their tone increases, that might not be the best choice for them. You might be kind of negating all of the work that you've done. So even though it's important for feeding for this patient, what you might do is passively take them up here and then actively ask them to do the extension component of the movement. So we passively take them up. So we didn't ask these spastic muscles to contract. Now we're going to actively ask them to do the extension. So they're contracting the muscles that have not been firing because they weren't strong enough to overcome the spasticity. So now they're learning how to contract those triceps, those shoulder extensors, those shoulder abductors, and that's going to further inhibit those spastic flexor muscles. So remember PNF, they don't actively have to contract in both directions. You could do one part passive and do the other part active. For the D2, this is your sword. If you're taking your sword out, I like to think of John Travolta too. He's too cool. I know, no one ever laughs. But this is D2 of the upper extremity. It brings the patient out into flexion, abduction, external rotation, which is far opposite of this flexor synergy pattern. So what happens with this D2 pattern, it's beneficial for your patients If they do have that flexor synergy, this is the active pattern you may want them to work in. Or if you're doing passive range of motion for your patient to try and get a little bit of stretching and passive range, if you've done other techniques to inhibit the tone and they're not strong enough to do anything actively, passively you might want to work in this D2 pattern because again, it's going to give you more of a stretch. It's also important that if your patient has decreased respiratory capacity, even if you're passively doing the involved side, if they can actively do the other side, look at that great chest expansion that I'm getting. Even if this was supine or head of bed elevated, combine it with the deep breathing exercises, looking at that overall health and wellness for the patients. Of the lower extremity, the D1 pattern of the lower extremity is coming up into hip flexion, adduction, and external rotation. It's kind of like you're crossing your leg. This is a pattern that brings you away from that extensor tone of the quads and the plantar flexors because it also combines dorsiflexion. As you're normalizing tone for your patient, if you want to work through a pattern that will recruit the muscles for swing through and gait, this is a good pattern to utilize. And then diagonal 2 of the lower extremity, they often say it's the fire hydrant. So the hip flexion, abduction, internal rotation, kind of like the dog coming up and out to go to the bathroom. This again is a pattern that you might use for passive range of motion of your patients because it's going to stretch them out of that extensor tone pattern. You could again also start to utilize it when they start to get some active control back. And the idea with PNF is that as we take the patients through these diagonals, we may have them actively contracting or we may be doing it passively. And the key is that the proprioceptive input that we're giving our patient is going to encourage them to have normal movement patterns. So when we give resistance to that muscle at the point that they can take it, we're going to use what's called a lumbrical grip. So we're giving our pressure from our thenar and our hypothenar eminence so that we're on one surface in order to better stimulate the receptors. If you resist someone, let's say their movement, and you're on both the flexor and the extensor surface of the muscle receptors are confused. They don't know which way to contract, flexors or extensors, and it'll diminish the response. So particularly with PNF, you want to make sure that you're only on one surface of the muscle, particularly the surface of the muscle that you're trying to recruit. With PNF diagonals, if you look at different people performing them, there's always a question as to, how far out, where is that diagonal pattern supposed to be? If you look at a clock on the extremity, you should be somewhere between 11 and 1 o'clock with the upper extremity and then 5 and 7 o'clock with the lower extremity. If you need a little bit of a guide, and what they found is that this particular positioning is what gives the most strength to the muscles. So it'll give the patient the best opportunity to recruit their muscles. So if you just inhibited their tone, and now you're trying to move them towards getting some voluntary movement, you want to maximize their opportunity for a response. When we have a patient with high tone, maybe you're working with someone who's in a coma or someone who is conscious, but they have such high tone that you can't even do passive range of motion. Or you're starting to get active range out of them, but their tone kicks in. So what do? There's a specific PNF technique called rhythmical rotation that really works well. And the way that this works is the PNF itself we know is in a diagonal pattern. Well, when we look at the extremity, PNF says use your neutral areas. So I'm on the styloid process and the epicondyles. And PNF says that if you do a long axis rotation of the entire extremity, So, right, I'm rotating this patient's extremity, kind of like internal, external, pronation, supination, smooth, and rhythmically, like this. That's going to be inhibitory. And what you do is you do that rhythmical rotation as you go through the whole diagonal pattern of the movement. So if this is my patient's extremity, I'm doing long axis rotation. At the same time, I'm taking them through the diagonal 1 or the diagonal 2 pattern. And that's going to be inhibitory to decrease the tone. And I'll tell you that it really works well for patients with a lot of different diagnoses. If you want to do just passive range to inhibit that tone, and then maybe you don't have to do it for every repetition, or if you're doing active range and the tone kicks in, you need to calm it down a little, just do a couple repetitions of them not voluntarily contracting, inhibit the tone, and then go back to active movement for them. The goal ultimately is rhythmic initiation for the patients, where they're able to do that passive, active, assisted, active, and then resisted movement. Think that your PNF patterns are not only done in supine, like I said, they mimic functional tasks. So this patient, I have them do a bilateral technique of lifting and chopping. So they're holding their involved extremity that maybe now we've inhibited tone. I teach them to hold around the wrist. And we're working on the pelvic control to inhibit the tone in this lower extremity. And I have them doing their PNF diagonal techniques that's giving the challenge and the weight shift and the stability to the trunk, while also giving some body-on-body contact to that upper extremity. So combining PNF with my developmental sequence, with borrowing a little Brunstrom of weight bearing also. If we look at the technique of agonistic reversals, this is another PNF technique where you have a patient, let's say you did rhythmical rotation, you inhibited them. They're able to start moving their extremity. So this patient's in a D2 diagonal. So they're going from the sword in their pocket to taking it out. So if I had flexor tone, I inhibited those biceps and those adductors. So I'm actively asking the patient to come up using the flexor component. As that patient comes up, that's great. I'm contracting the middle deltoid. I'm contracting the triceps to get them up. I'm going to isometrically ask them to hold there, but how do I get them back down? If I voluntarily ask them to contract the pecs, the internal rotators, and the biceps, what happens is I may increase their tone. I don't want to do that. So once I get them up there, what I will do is try to push them with my resistance down into the extension And as I'm pushing them, they're still contracting all those flexors that got them up there. They're doing an eccentric release to get down. So I'm still firing all these muscles that got me up there, slowly releasing these contractions of that middle deltoid and triceps to get me back down. That's reciprocally going to further inhibit those spastic muscles. So you can actually get the patient to go through the range of motion, but they're never recruiting those spastic muscles. So you're able to build strength of the other muscle group. So it's a little confusing, but the technique really works well. So we can utilize a lot of different neuro rehab techniques to try and improve the strength once we decrease the tone, being mindful that we don't want to trigger that tone coming back. There are many different complementary interventions that are emerging as techniques to utilize with our patients who have high tone. And whether it's their primary diagnosis that they have, that you're treating, or maybe you're rehabilitating the patient from an ankle sprain, but they also have multiple sclerosis, well, you need to think about, well, how am I going to strengthen that ankle differently than my orthopedic patient who doesn't have a neurologic insult? So some of these techniques may be beneficial also, whether it's primary or secondary diagnosis that the spasticity is. Electrical stimulation can be utilized in several different ways. We can utilize electrical stimulation by directly applying it to spastic muscle in order to fatigue it out and inhibit it. They've done several different research studies looking at application of electrical stimulation to the point of a tetanic contraction, and they have found that it has been beneficial for the wrist flexors, the knee extensors, the plantar flexors, to kind of fatigue them out and help decrease the tone. Another way to utilize electrical stimulation is to engage that reciprocal inhibition component. So let's say this patient has spasticity of their biceps. So we have spasticity of the biceps. Rather than tackling those biceps directly, what you can do is apply the electrodes here to the triceps. So you apply the electrodes to the triceps. You're going to utilize your electrical stimulation for strengthening parameters, a 30 to 50 pulse contraction. And that's going to tell those triceps to fire. What happens is if you set a higher ramp time, so set a long ramp up time of your electrical stimulation. So that means when the current turns on those triceps, it's going to take it maybe 3-4 seconds to come on. So it's slowly giving stimulation to those triceps, slowly starting to depolarize the nerves and recruit those triceps. And as those triceps are being obligated to contract from the electrical stimulation, what happens is the signal goes up to the spinal cord, and reciprocal inhibition says if the triceps are contracting, the biceps have to shut off. There's that inhibitory signal that comes back down. So the E-stim here in red is making these triceps contract. And then what happens is the signal coming down from the brain is going in spinal cord, I should say, signal coming down to these biceps here in yellow is going to be inhibitory, reciprocal inhibition telling them to shut off. So maybe this patient now can actively extend that elbow. So we can utilize the E-stim on the antagonist of the spastic muscle to obligate that spastic muscle to shut off and meet with some success. And the research is showing that this actually has been able to be achieved in several patients. TENS is something else that's emerging as an option to be utilized for patients who have spasticity. And what they're finding is that TENS we know is sensory, but we also said earlier on that pain can trigger increased spasticity. So what they're finding is that by applying TENS along the dermatome that corresponds to the regions of spasticity for the patient. They did this in patients with spinal cord injury, that either using the dermatome or the nerve path, specific neural pathway of a nerve distribution, let's say the common peroneal nerve, if it was the gastrocs that were spastic, that by applying the low rate TENS and high rate TENS kind of combination parameters, where they would use 100 hertz frequency and a 2 millisecond ramp with what they're finding is that by triggering that sensory stimulation, it is going to decrease the perception of pain. And by decreasing the perception of pain, it actually inhibited an exacerbating factor of the spasticity. So basically, if we said pain increases spasticity as a response, they're saying, well, why don't we decrease the pain that someone may have because of their high tone, and that should alleviate some of the spasticity. So it's almost trying to teach the nervous system how to modulate the sensory input so that it doesn't trigger that spasticity response. So again, emerging, they're starting to look at that. Mirror therapy, we're seeing utilized for many different diagnoses. And this is where you create a box or a setup where the patient is going to have a mirror in the middle here, and they place their involved and their uninvolved extremity each on a different side of the mirror. The reflection part of the mirror is going to show their intact extremity. What happens is, as they create movement of their uninvolved extremity, and they're looking at that reflection in the mirror, they're visualizing it's their extremity with the spasticity that's actually moving. What they have actually found when they are looking at brain scans of individuals who are participating in this is that there is actually activation of the mirroring neurons in the brain, and it's another way to try and reestablish the connection. The key here is the brain really has to believe that it's the opposite extremity that's moving. So look at this gentleman here. His left leg is his uninvolved leg. And then see the reflection, I'll make it red here, of his right leg. So his brain thinks that that's really his right leg. The reality is the right leg is on the other side of the mirror, and it has some tone and inability to move in it. So as the brain is looking at this, it has to really believe it's the other extremity. So if the jewelry has to be the same, clothing has to be the same, because the brain is still, cognitively aware. If there's a tattoo or something that's different, you have to try to position the extremities similar to start to convince the brain that the movement is actually occurring. What they found looking at individuals with CVA and traumatic brain injury is that in some of the studies that they did find a statistically, clinically important improvement in ADLs, ultimately of the patient because the spasticity was decreased. That in individuals who had traumatic brain injury, that there was an improvement in the spasticity so that it was allowing greater range of motion for grasp, for performance of motor ability of the upper extremity. So this is an emerging technique that we might see utilized. Vibration is another technique that many of you may already utilize in an isolated area. Similar to utilizing icing, where we go from the insertion of the muscle up towards the origin, applying pressure to the muscle belly of the antagonist opposite the spastic muscle. So this is that patient who has gastroc spasticity. By applying vibration from insertion to origin of, let's say, that anterior tibialis, that is triggering a stretch reflex and encouraging firing of that anterior tib to not only help strengthen it, but then reciprocally it's going to further inhibit that spastic muscle. In patients with multiple sclerosis, they've tried utilizing this on the rectus femoris and the gastroc, where they would vibrate up for 6 seconds, asking for voluntary movement along with it, and then relax for about a second, and they did it over a 30-minute period. They did find that there was decreased spasticity, and the patient reported less fatigue in that spastic muscle, less muscle discomfort. So not that you would necessarily do it for as long as 30 minutes, but it does show that maybe there is something that helps not only decrease the spasticity, but encourage voluntary recruitment of the muscle antagonist. They've kind of expanded this idea to look at, well, what if we vibrate the whole body of someone who has significant tone in multiple regions? And the idea here is whether it's a standing kind of frame. This is an example of one where the base is going to vibrate. That there's a mechanical vibration that's occurring. It is oscillating so fast. It's 30 to 50 oscillations a second. It's extremely, extremely fast. And the thought is, as this mechanical vibration is going up into the body, all the different mechanoreceptors, think of every joint in the spine, in the extremities, that all the muscles spindle are being kind of triggered at the same time and the same rate. They're theorizing that it starts to kind of coordinate that muscle spindle firing, and ultimately the GTO starts to recognize this kind of repetitive movement and firing, and it says, oh wait, I don't really have to respond to that. Let's shut down that response. So it becomes inhibitory then to help decrease the tone for the individual. So some of the research is saying that it kind of is helping reestablish that connection between the periphery and the cortical response in order to relax the firing. They've actually done some studies on children with cerebral palsy, those that slept in a traditional bed and those that had a bed that had the vibration added to it. And they both all received the same physical therapy interventions, and they found that over a course of 12 weeks, even with just 20 minutes of lying in the bed that had vibration for the whole body, that they had improvements in their gross motor function, more significant improvements in their motor control than the kids that just had the straight PT. When we think about complications of spasticity, we need to bear in mind that joint contractures can occur, that as we are trying to combat this spasticity, that the patients are having that soft tissue shortening that's occurring. There's actually an alteration in their sarcomere length, so the length tension relationship is changed, so it takes less of a stretch in order to trigger that muscle response. When we consider contractures that are occurring, it could be of the shoulder, the wrist. These are some extreme positions of these joints that are actually leading to some subluxation. So there may need to be additional coordination and medical management for these particular patients. What they're finding in terms of how can we tackle the contracture component that occurs in these patients with spasticity, traditionally splints are something that were being utilized. And the studies, they don't really lean one way or the other, that it's not necessarily saying splints don't work, but there's not overwhelming evidence that they do work, so it needs to be on a case-by-case basis. But just to give some examples, they looked at patients who had upper extremity wrist spasticity, and they compared using a night splint in a neutral position versus the resting hand position of the 10 degrees of extension. And they found that there really wasn't that much of a difference for the patients, that both did lose range of motion at a similar rate, but that the self-report, even looking at those components and the impact of life, weren't that different. Looking at children who had cerebral palsy in Australia, they looked at teenagers with lower extremity spasticity, and they compared those who received stretching with electrical stimulation to just stretching alone. They said that those that had the E-stim concurrent with it, it did help a little bit. But generally speaking, they're not finding that one particular intervention is better than another for managing the spasticity of the patient. Something where we are seeing a difference is that patients who present with spasticity, when they ambulate, they may go into genu recurvatum at the knee. So looking at this patient here, looking at right leg, we have good straight alignment at that knee. And this left leg here, we're seeing kind of that posterior bowing in the popliteal area because there's so much quad tone. It's actually creating a hyperextension in mid-stance, or because there's so much tone in the ankle. Think about when you put on high heels. Gentlemen, I'm sure you think of this all the time. When you put on your high heels, in order to balance, your knees go out into extension. What happens is when that patient has high tone and they have plantar flexion tone, when they put their foot down, if they don't have range to get into neutral, it's going to translate that force and shift the tibia, creating extension at the knee. So when you're in plantar flexion at your ankle and your foot has to be flat on the floor, right? So I'm going to simulate it with this. So you have plantar flexion at your ankle, right? So plantar flexion at your ankle, you put this foot down, well, now that's going to shift your tibia and create that recurvatum at the knee. What we can do for these patients is put them in an AFO that's set in different degrees of dorsiflexion. This one's rigid, but I'm going to pretend that I can change the angle of it. So when you put the patient into an AFO that's set in more dorsiflexion, you're essentially changing this angle at the ankle. So for this patient here, when they are going at heel strike, the heel is going to hit the ground, but this ankle is set in dorsiflexion. So on the right-hand image here, when that foot becomes flat on the floor, because see I have this small dorsiflexion angle here, it actually causes the tibia to be more forward. So in standing, the tibia is translated more forward. So at the knee, that actually creates more knee flexion. So that's going to take the pressure off the knee. It's going to allow less knee extension during gait, less stressing of those posterior structures, so it's more beneficial for the patient. So an AFO that's set in a little bit of dorsiflexion, when that patient goes into stance, see how this tibia is more forward? That's going to allow a little flexion at the knee to take the stress off. So we can use that to try and compensate for some of the tone. Contracture management does need to be multifaceted for our patients that we're looking at, that we need to stretch. Then we need to encourage normal movement and decrease the spasticity for the patient. Looking at our muscle stretching techniques, it's going to help account, we know, for those viscoelastic changes, to account for some of that sarcomere length change, to reestablish the muscle length. The evidence, again, is varied, that when they looked at large Cochrane reviews with large cohort studies, patients receiving prolonged stretching versus no stretching, it really doesn't say that it made a huge difference, but it couldn't say that the patients wouldn't have been worse off over the long haul, maybe months and years, because even gaining 1 degree of motion, if this is a lifelong condition for them, multiply that and amplify it over years, that could have an impact. So we're not saying not to stretch, we're just saying the research hasn't decided what kind of stretching is best or which way to go with your stretching, how helpful it can be. So you need to look at it on a case-by-case basis. But I would make the personal argument that even if we're just maintaining range and not losing it, it can have a beneficial impact for the patient in terms of not triggering that stretch reflex and in their quality of life. Either way, you want to be on neutral zones when you're stretching, so you're not facilitating that spastic muscle. You want to think about the environment you're stretching the patient in, particularly athletic trainers. If you're out at the gym doing general health and wellness, don't be in the busiest part, because that patient may be able to participate in health and wellness training, but when you get to that stretching point, maybe their tone is being increased because now they're exhausted and emotionally stressed potentially too, and it's a busy gym. Bear these things in mind. The velocity of the stretch that we're looking at, we have to be mindful of that we are looking at slow, sustained stretching. So they're saying like a low load, about 5-second to load onto your stretch is what's recommended in order to not trigger that stretch reflex and that spasticity when you go into the stretching technique. There's also some discussion to look at myofascial techniques. And it totally made sense after I read the study and looked at the images. And I almost said, well, right, why didn't I think of that sooner? I always did myofascial release on my patients who had cerebral palsy, because a lot of them oftentimes had multiple surgeries as children. So as they aged, we saw that the myofascial restrictions were creating pain in other areas. But it also helped improve their tone and their mobility. The research is now figuring out why. Think about this. Here's a patient on the top left image where this is the tendon of the flexor carpi ulnaris, and they've severed this tendon. So this is not an actual patient. This is a cadaver dissection here. But they are severing the flexor carpi ulnaris tendon, and we can see all the fascial connections in here. So we know that our fascia is intertwined with everything. What they found is that even though they severed the muscle for the wrist flexion, so theoretically, right, that muscle spindle shouldn't be firing to trigger that reflex arc, the spasticity should have been gone. They actually found that there was still some loading of the muscle. There was still some tension being developed in terms of the spasticity. So what the research was saying, and they actually excised out on some patients the muscle fibers, and they looked at the muscle fibers. And what they found is that on the top image is the paramecium around the muscle fiber, and it's normally thin. On the bottom right here, look at all this redness and the thickening here. They found that the paramecium, that fascial tissue around the myofibril of patients with spasticity, it actually becomes thicker, and it has biomechanical adaptations that even with the tendon severed, it was still putting stress on the muscle, creating tone and myofascial loading. So they're making the case that some of this passive stiffness for patients may be related to fascial restrictions, so we might want to explore interventions. They're taking it a step further and analyzing genetic factors that might be contributing just to the different structural integrity of the muscles in patients. And they're finding that there are certain differences in coding that lead to different collagen development in individuals with cerebral palsy. And they're starting to theorize that some of that is creating or contributing to the abnormal reorganization of the muscle fibers, and may eventually be one of the contributing factors to why there's so much more tone in addition to everything we know. So by trying to look at what's responsible, they're hoping that they can develop new interventions and techniques pharmacologically that can help manage the patient's tone. Looking at pharmacologic management, there could be generalized regional and local applications of pharmacology. And the intrathecal baclofen pump is something that is utilized. It's a small device that is implanted. It's about 1 inch thick, 3 inches round, that's implanted into the patient. And then it is going to have a thin distribution tube that is going to allow a small dosage of medication. Norosol is one of them that is going to be transmitted into the patient. It's implanted into the spinal cord. And this is going to allow release at the location very close to the spinal cord where the receptors are located. What GABA is an inhibitory transmitter. So the medication works very similar to GABA, and it's going to be transmitted here right near those inhibitory neurons in the spinal cord. Because it is being delivered right where it will act, they can use a low dose, and it's a pump, so it's continuous 24 hours a day. And what they're finding is that it can stimulate those inhibitory neurons by binding to those sites and help decrease the tone for the patient. What you need to be aware of in your patients that have this type of implant is that it does have to be refilled. So make sure that you remind them that they do have to keep those appointments, because if they rapidly run out or stop using this, we can see significant changes in their tone. We also have to be cautious of monitoring these patients for signs of infection, because the catheter is implanted in the space in the spinal cord, that there is a direct mode. If there is a superficial infection that moves deeper, it does have a portal of entry into the spinal cord, so there is a potential greater risk of, let's say, a meningitis or a central nervous system infection that can develop. So be aware of that in monitoring these patients. What they found with the intrathecal baclofen is that it does have improvements for patients with many different diagnoses. in terms of improving their not only spasticity scores, but what's interesting is that look at the metabolic changes that occur for patients. What they found is that even though their resting metabolic rate may be unchanged, their body fat increased and their lean body mass decreased. And it's theorized that these patients, when they receive these pharmacological managements that decrease spasticity, that's firing of the muscle, that requires energy, that may increase their dietary intake, that when the tone is significantly decreased, that there may need to be a dietary component of adjustment so that there is overall balancing of their nutritional needs, because the demand is less because the muscles are firing less. Thought that was interesting that wouldn't have necessarily considered that. Looking at Botox injection, this is going to bind to the nerve endings of the spastic muscle. Once someone receives the Botox injections, they say onset about within 7 days that you start to see relief. They do this under EMG to locate the appropriate nerve endings. And when they provide the injection, this is going to inhibit the acetylcholine release, so the spasticity muscle contraction can't occur. And it's actually over time, neural sprouting and healing starts to occur. So over, they say, about 3 months, the patient has return of their spasticity. But the benefit here is that as you decrease the spasticity of the muscle, that gives you the opportunity not only to gain range and stretch, but to gain strength of the agonist and the antagonist for functional movement. So it's kind of like that's your window of opportunity for the patient in order to do splinting and other therapeutic interventions to get some function for them. And then they may need another treatment. What you need to watch for is the black box warning on patients who receive Botox. We need to monitor these patients closely because the Botox doesn't necessarily stay right at site where it's been injected. In some patients, it can have toxic spreading throughout the body. So you're going to monitor your patients if they start to have dysarthria, dysphagia, those swallowing difficulties, speech difficulties, respiratory, that isn't attached to anything else, and you know they've had the Botox, might warrant that referral back to the physician because they could have spreading. The research is supporting the use of Botox in order to show improvements for patients. But in terms of the FDA, they said that it's not fully established that we can't just replace all our traditional techniques yet. But there are several different studies with patients with different diagnoses that are supporting the use of Botox to improve function and mobility. Surgical techniques may be necessary for some patients if they're not receiving relief from the physical therapy and occupational therapy interventions and medical management. In terms of surgical techniques, the ones indicated specifically for spasticity, one is that they can do a dorsal rhizotomy. So they would come in here, and instead of severing the whole nerve peripherally where you lose motor and sensory, they'll come in at the spinal cord level and just sever the dorsal component, which dorsal is our sensory. So it's almost like that afferent trigger of the reflex arc is going to be triggered. It's severed, so it can't be triggered. So what we need to think of as therapy now, those patients, they retain their motor component, but they're used to having a spastic muscle that gives some tension and stability to a joint that is now gone. So please be mindful that you really need to make sure you strengthen those patients to get their stability back. If we look at another surgical technique that could be utilized to address the muscle lengthening, that would be your Z-plasty technique. And what they actually do is go in, let's say, to the Achilles tendon, and they actually make like a Z in it. So by making that Z, now they can kind of elongate it to get some muscle length for the patient. But the benefit is it maintains contractility still. So you may be able to teach that patient then to reutilize that muscle so it'll retain contractility of the gastroc. You can strengthen the anterior tib to get better range of motion. So what they found related to spasticity, and what I hope you glean today, is there are many different techniques that we can utilize: surgical, pharmacological, and treatment interventions. Hopefully I gave you a glimpse of some different ideas you can try with your patients in order to help manage their spasticity and encourage functional mobility for participation in their different work and life activities. Asking what interventions are recommended to inhibit lower extremity flexor tone when coming into standing to prepare for gait. And what you'll probably find is, as we go through the different developmental sequence and different techniques today that are inhibitory for tone, you might find that there are techniques to utilize in lower developmental postures. So instead of working on sit to stand, maybe taking that patient and working them more in quadruped to develop that pelvic control and inhibit the tone of the lower extremity and encourage movement and coordination of the muscles as that tone is released, and then put it back together into your functional tasks. So sometimes working in a lower developmental posture, even supine bridging activities that are still closed chain, can replicate sit to stand without the increased demand of controlling the proximal body, so the patient can meet with more success and then put it back together into the functional task. Or some of the bow bath transfer techniques that we're going to take a look at that encourage more normalization of tone and crossing midline and symmetry may work for a patient who's having difficulty with sit to stand and tone kicking in. Patients with flaccidity, that's almost a whole other topic. The mechanics are different of what happens when a patient has flaccidity and a lack of muscle tone. Depending on the joint, they may have subluxation and overstretching of the structures that's contributing to their pain. Um, Again, that not to push off the answer, but that's almost a whole other topic as to the reasons biomechanically and neurologically why someone with low tone has pain with range of motion. But the arthrokinematics are something I would look at first to see if there's not an impingement or something going on, if it's the shoulder with alignment because of the flaccidity. So the question is, approximation techniques, should the pressure be for a prolonged duration? And would it change the results if the approximation was held on and off for the duration? What happens with approximation is when you get your patient into the different posture, let's say they are tall kneeling and you're approximating down through the pelvis, you're approximating because you notice that they're not stable in the posture. In the context of this course, we're saying that maybe that extensor tone in the lower extremity is kicking in and they can't maintain their alignment. So you're giving an overpressure around that hip joint to help inhibit around that hip joint the muscle spindle firing. And then if this is the knee, the pressure down into the knee over that quad tendon is inhibiting the quads. So what you're going to do is you're going to approximate to help them hold that position. And the hope is you're decreasing the spasticity so their muscle contraction now starts to kick in to hold the position. Ideally, you would be able to let go and they could retain it. Likelihood is that may not happen right away. That may take a session, multiple sessions. It depends how quickly recovery is happening. You may have to keep holding that approximation while the patient is trying to learn to assist with controlling that movement. And then give them a break at times because you are asking them to put effort forth. So depending on where they're at in the recovery, you're going to see how long you have to hold it for. Your goal would be for them to be able to maintain that posture without your support, but it may take time to get to that point. And then the next time you take them to a more challenging posture, you may have to go back to giving them that input. as they learn how to control the muscle, and you're decreasing the tone in that other posture. So the question is, could you explain how the action of applying the pressure to the joint stimulates the proprioceptors to inhibit the tone? When we have a joint that has that muscle spindle sensing the change and triggering that reflex arc, if you're starting with high tone, because weight bearing does several different things, but we're talking about if you're starting with that increased tone, that compressive force around the joint, it's, if you think about it, it's pressure, it's compression. So the muscle spindle is not being stretched. It's kind of being shortened in a sense, just to give you a visual. So it's dampening. It's telling that muscle spindle you don't need to be firing. So it should help decrease that reflex arc, because it's not going to trigger the obligatory motor response of the tone, and it should help decrease the tone. The question is, with the rocking technique, should the patient lie on the effective side for weight bearing? The gentle rocking technique, it would just depend on what you're putting together. Eventually, we would want our patient to be able to move and roll to the affected versus the unaffected side. So depending on the task that you're doing, you can just use the gentle rocking technique as like a transition or kind of like a pause to help inhibit tone and then resume whatever activity you're doing, whether they're lying on the weight bearing, on the involved or the uninvolved side, will specifically depend on kind of what task you're working on at the moment that increased their tone. The question is, what if the person with spasticity has too much pain to be weight bearing? Definitely a consideration. We don't want to exacerbate pain because that actually can further increase the spasticity. You want to try and figure out, what is the pain coming from? Do they have nerve compression? Is it from skin breakdown, or is it just from the sustained, contraction? If you're ruling out other pathology that needs to be addressed, and just weight bearing through the extremity increases pain, definitely look at the alignment, and maybe that's a patient you want to take down and use some of these other manual contacts techniques, or when we'll next talk about PNF for range of motion, you want to maybe do other techniques, Brunstrom and PNF, to inhibit their tone enough so that you can get good arthrokinematics and alignment of the joint to perform range of motion and stretch the tissues, and that patient may not be up to weight bearing yet. You may have some other things to address for them first to determine the etiology of their pain. Is Remisti's phenomenon essentially a type of associated reaction? Correct, yes. It's an obligatory response that's happening in relation to a stimuli, so it's an associated reaction that we can then use in different ways to help manage spasticity and encourage active motion. So the question is, do you think inhibiting tone on a patient with Parkinson's is advantageous? If it's determined that the increased tone, particularly patients with Parkinson's tend to present with more rigidity, whereas the agonist and the antagonist, often in the trunk, if it is interfering with their movement, then you might want to try and utilizing some of these techniques to decrease that tone in order to allow more active movement to occur for as long as possible. Question is agonistic reversal effective because it's fatiguing the spastic muscle? Technically, it's not fatigue. What's happening is with agonistic reversal, and I'm just going to do it use biceps and triceps as an example, that if my triceps extend me, my biceps are spastic, my triceps extend me out, instead of now taking that muscle, that biceps, and asking it to contract to pull me back, which may increase its spasticity, what I'm going to do is be pushing into the elbow flexion, so my triceps have to actually eccentrically let me slowly come back in. So because I'm maintaining a contraction of these triceps, I'm voluntarily recruiting those triceps. Through reciprocal inhibition, the neuron impulses are not being given to the biceps. So it's essentially kind of overriding that spasticity response. It's forcing those biceps to shut off because I'm contracting the triceps through reciprocal inhibition. So it's not necessarily fatigue, which has like an energy component to it. It's more the reflex is just not being triggered, or it's being overridden in a way. Can vibration technique be done manually? The research that I read all utilized a piece of device or equipment to transmit that vibration into the targeted area of the muscles or into the whole body, because it's happening at such a high rate. The research I read said it's 30 to 50 vibrations per second a piece of equipment needs to deliver it. Another question is, has cupping been found to be helpful? Cupping is emerging in general as a technique. I have not specifically looked at it related to spasticity to be able to answer that. How do you address retropulsiveness with sit to stand transfers? The hands on the scapula seems to promote extension when you want to promote leaning forward. When you're doing the hands on the scapula, the fact that your hand is on the scapula is your point of control. So you're on kind of like a bony area to some degree to be able to control the trunk. And it actually to give the individual a nice weight shift forward, which is what a lot of the retropulsive patients are lacking. Get them far enough forward over their base of support of their feet and then have them stand up. So it may actually allow you to give them the input, kind of mirroring your weight shift and standing, so that they're recruiting and timing and moving their weight appropriately to the right position to achieve stability when standing up. So you might want to try it and see if you actually have better control. You're not pulling them up, you're teaching them to kind of weight shift their body weight. Here's another question. Is there a do-it-yourself method to make a mirror therapy device? Actually, in several of the research studies, they did describe that, so you can go to the references for that, or the internet is a vast place. There's lots of information out there that you can read with a safety-minded and clinically keen perspective to determine what would be appropriate. But there is a lot of information out there on kind of do-it-yourself mirror devices.